Originally from rural Illinois, she loves being in nature across all 4 seasons. She's delighted to join the National University community for Public Health Week 2026. Dr. Neubauer. Next to Dr. Leah Neubauer is Dr. Jennifer Malin. She's a medical oncologist with over 15 years experience as a physician, designing and implementing population health initiatives in oncology, rare disease, and precision medicine for large national payers and healthcare delivery organizations. As Senior Vice President and Chief Medical Officer of Optum Health Solutions, she led teams that developed clinical programs to improve health outcomes and value for patients with complex conditions, including cancer and rare disease, and had clinical oversight for Optum's Center of Excellence for Transplant and Rare Diseases and the clinical guidelines used to determine coverage. Dr. Malin currently consults to and advises a variety of companies and organizations, including new ventures seeking to transform healthcare through new delivery models or artificial intelligence, health plans, and life science organizations. She maintains a clinical practice in oncology at the VA Medical Center in West Los Angeles. Finally, we have Dr. Tyler Smith, Professor of Public Health Epidemiology and Biostatistics at National University. He received his BS in mathematics from Chico State and MS in statistics from the University of Kentucky and PhD in epidemiology from the University of California, San Diego. He's been invited to serve on 2 Institute of Medicine committees, the National Academy of Sciences, Engineering and Medicine, as well as invited to chair the SAS Global Forum, and is an active scientist with 160 peer-reviewed publications and counting, cited nearly 10,000 times in major scientific journals, including JAMA, the British Medical Journal, American Journal of Epidemiology, International Journal of Epidemiology, and the American Journal of Public Health, along with 300 scientific presentations. Dr. Smith is an internationally recognized military health researcher and post-deployment health expert, and has been an invited keynote speaker both internationally and in the US. I suppose I should say a little bit about me. I am the Associate Professor of Public Health and the Academic Program Director for the Master of Public Health program and the Bachelor of Public Health program here at National University. And like Dr. Tyler Smith, I am an epidemiology and biostatistician working for over 28 years in public health. And I won't say more than that because I want to get started. But thank you to our very distinguished panel for being here. And I'm going to ask basically the same question, but a little bit nuanced based on the background, which you've just learned of each of our participants. So I'm going to start with Leah, since you're next to me. So you're involved in training the next generation of public health professionals. How is the misinformation environment changing what you have to teach? And what skills does a public health graduate need today that weren't on anyone's radar even 10 years ago?
Right. Thank you, Sarah, Dr. Cook. It's really great to be here and really appreciate the kind of opening question, being focused on training and education. And I think first and foremost, because that really is the reason all of us are here and all of us are engaged in the work that we do. My own training is in adult continuing and professional education. So on the one hand, I think very broadly about how adults learn across the personal and professional lifespan. Thinking of Sarah's question in my own practice and how I answer that, it certainly starts thinking of that lifespan. I do design, implement, teach curricula for MPH, for graduate students, and also by extension of my training and my research, happen to think of training and education in real world, what we would call non-formal education settings. The answer in my mind is very much the same. Ironically, it's a link back to my own training, which at the bachelor's level is in communication studies and is in really thinking about the core art and science of communication. Most folks hear communication and they think about talking and they think about words. What we actually know is when you say something, you use your body, Folks on the receiving end of a message are actually more likely to pay attention to your gestures, to your tone, to your nonverbal communication, sometimes more often than the words themselves. When I think about this opening question and what immediately comes to mind, it invites questions and attention to how our students and our trainees are actually engaged in communication, which is as much understanding theories and models of communication as it is also being great listeners, being great observers, understanding that you might have the great science and you might have the great words, but the absence of knowing who your receiver, who your community is on the receiving end could really impair how you communicate. So kind of thinking of it all together, I go I think, back to some formal training in communication, but I'll close by saying I think also back to some common sense. As far as I know, I've been communicating since, my first months of living. And I think it's really with that humility and the recognition of communication that we have a lot to learn and grow in that space. And I also don't think it's all on us in the higher ed environment. I think it's a real invitation to communication across the lifespan.
Thank you. Jennifer, you worked at the intersection of population health and medicine, so you're in both worlds, but also within healthcare systems and in payers. Where do you think misinformation is hitting the hardest? Is it the patient, the clinician, the healthcare system? Where do you think misinformation and the current environment of misinformation is hitting the hardest right now?
It's a really good question. I mean, I think interestingly enough, bring my mic up. Interestingly enough, I think for clinicians, over the last several decades, I think there's been kind of concerted efforts to focus on organizing information, having evidence-based guidelines, and there's just some fabulous publications and tools out there, like Up to Date is one that comes to mind, that in contrast to when I started in school, where you had like a textbook that was paper that was already 5 years out of date by the time it was published. These all get updated as new publications come out. So from that standpoint, I think from the clinician world, there's maybe some information overload because there's just so much information out there, but I would say there's much better access to high quality information across the board. I think, I was thinking about it from the patient perspective. I think the way that communication has evolved over the last 10 years on the internet, I think makes it much more challenging to even know how they're receiving information and what's misinformation. I mean, in the early days, maybe 10, 15 years ago, clinicians would sometimes be frustrated because patients would do a bunch of searches online and come into their appointment with like 20 pages of, 100 pages of information. And so you'd have to take all this time to kind of explain what was relevant, what wasn't relevant. But I don't see people doing that as much anymore. And I think it's likely because they're, rather than doing their own searches and kind of coming up with lots of information, there's probably a lot more where it's social media, it's videos, it's, TikTok. And so it's not really something that they can print out and share, but that I would assume they still are coming to the appointment with some perspectives that they've seen online, and that informs their perspective, but they may not be sharing it with their clinicians as easily, just because, you know, there's not kind of a shared medium anymore like paper to share it. So yeah, so I think it's a challenging environment to figure out where patients are getting their information from. And then, you know, some of the other hats that I've worn in large organizations, I think, you know, building back on what Leah was saying, is that a lot of whether people are receptive to information comes down to trust. And so if you trust the organization, you know, maybe kind of whatever format it takes, there's obviously better and worse ways of communicating. But if it's a trusted organization, patients, community members, you know, individuals are likely to be receptive to the information. But if it comes from, say, an insurance company or an organization that has low trust, even if it's high quality information, people probably are not receptive to it.
Thank you for that great response. And I will come back to all of you, so don't worry, you have more opportunities. I want to make sure that we get all the different perspectives on our panel. And Dr. Smith, as an epidemiologist who lives in the world of data and peer review, what is it like to all of a sudden have the standards of evidence seemingly not matter in the public arena as much as it did, and really maybe ignoring the science?
You're exactly right with how quickly the field changes based on non-science, and that's scary to me, but I think there is still a foundational piece that we all fall back on, which is the science of the epi or the statistics. I want to bring up an example that I've been wanting to talk about, which has both misinformation and disinformation, changed our lives, changed hundreds of thousands of people's lives, drove up fatality, morbidity. That is the paper that Wakefield put out in '98 in the Lancet. And Lancet, if you don't know about journals, is a very highly respected journal. They put out something on a series of 12 kids that basically pointed at the MMR as the reason for autism, if you recall that. And at the time, it was like, that's it. And everybody overnight, 30% stopped doing vaccine, right? Even though it was retracted about 12 years later, and people lost their certification and things like that, you'll still talk to people today, and I do regularly, that say, oh yeah, it causes autism, and they'll load a bunch of other vaccines onto that same list. And you're like, whoa, 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 there's no research, there's no science that points to this. Well, the practical implications of this are the mortality, especially with measles and infants. And you see that in San Diego County, you see that across America when we have these large outbreaks. In reality, it's probably stemming a lot from not having that herd immunity from 90% of our kids getting the vaccine. You hear about it after COVID, and whatever way you feel, that's fine, but a lot of people use that autism and MMR as a reasoning of why a vaccine isn't good to take. So that's something that actually had a straight numerical impact on mortality of infants and children that people don't talk about. And the disinformation came from Wakefield, who had a financial disclosure issue that he lost his license over. The misinformation comes from people continuing to say the same sort of thing over and over again, when in fact the whole so-called science was retracted almost 2 decades ago.
Thank you, Tyler. I think this would be a good time to bring up the slide, if you could. Thank you. I promised I wouldn't do this tonight, and that's to be the teacher, but I have to play a role in this panel as well. And you're getting fresh-baked into our curriculum some distinctions that I'd like to make between misinformation, disinformation, bias, and a new brand of disinformation and misinformation, which is, or more misinformation, and that's AI hallucination. So we've got this new possibility of information being made up and then spread. And just for the purposes of furthering the discussion, because Dr. Tyler Smith mentioned disinformation and misinformation, I just want to be very clear about what we're talking about, as well as bias, which we don't talk as much about that. Bias is not a bad thing. Bias is something that is inherent in the studies that we do. And as epidemiologists, we try to address bias in systematic ways so that we can develop an evidence base. It doesn't mean that we're biased towards a specific outcome. It means that anything outside of a clinical trial or a randomized study is inherently going to have some sort of bias. And in public health, we're prepared for that. That's what we study. That's what we know. Disinformation is a whole new category that public health has not had to deal much with, which is the intentional, deliberate misinformation that is created to mislead or cause harm. Okay? And that's used maliciously, and the intentions can be political, they can be monetary, and that's something we have had to deal with when you think about snake oil salesmen or all the remedies that have leeches as a medical practice, right? In some cases, it had to do with just lack of information. But then there's misinformation is a bigger problem, which is where people simply repeat false information. They heard it on the news, they saw it on the internet, and they didn't take the time to question it, and then that gets perpetuated. So, a lot of what we're calling misinformation or disinformation, the difference is in terms of intent. And then, as I mentioned, as when we talk about public health and especially academic public health, what we were really originally trained to deal with was bias. These other things are kind of new to us as far as us having to address those specifically, and it's really been a wave. So I just wanted to highlight those differences, and for those of you at home, you can think about what those differences are. Okay, well, we've gone full circle, and I just did my bit. Leah, when a student comes to you now genuinely uncertain about what sources to trust, including sources that public health has traditionally endorsed, let's mention the CDC or National Institutes of Health, what do you tell them?
Wow. I think first and foremost, one of, at this moment in time, places to start is actually to contextualize, to actually listen and talk with my students, to really think about what they need, where they need to go, and why. And this immediate response is happening when I've literally spent the last academic year rewriting curricula that were based on previously available public data sets. And so in many ways, one of my first answers to those students is happening, ideally, in the days and weeks before, where we're actually thinking, one, about the structure of what we're providing and supporting to our students as places to go and places to look into. I certainly benefit a lot from local data, from county level data and state level data. And also now I would say fast forward to months, 15 months ago, fast forward to now, many of our peers really set forward, rightfully so, to archive many of our data sets and databases. I started the response with context and conversation. And I think as a critical adult educator, that's actually one of the best things I can do. Certainly in tandem with offering the paths. The conversation piece to me is important because everything we do in public health need be historicized, especially at this point in time, right now. So this conversation piece, probably akin to my previous answer around communication, is this is not only a moment to just direct our students to what we have now sussed out to be reputable, as it is to also engage our students in knowledge of why things are the way they are and what we can do to make them better.
Thank you. I'm going to go in order, no surprises. I thought about throwing Tyler a curveball by having him go next. But so Jennifer, in oncology specifically, the stakes of misinformation are immediate and sometimes fatal. What does it look like clinically when a patient has been down a misinformation rabbit hole before they reach you? Maybe weren't getting the care that they should be getting.
Yeah, I mean, I think the benefits of a one-to-one relationship with a patient is that again, as we were talking about earlier, you first seek to establish trust, and so then if they trust you, they're able to take in the information that you provide. And then I would say there's always a balance. I mean, people can get misinformation, but in a clinical setting, you have to always think of it from the standpoint that people also come with different values and preferences. And so I spend a lot of time clinically trying to understand whether whatever perspective they're coming with, is it based on misinformation, or is it that they because of their life experience, they may value life extension, taking a medication that causes side effects. They may have a different perspective on that than I might. And so, I feel in those settings, it's just really, in a one-on-one relationship like that, you have the privilege of being able to try to understand their perspective and try to discern whether they've been misinformed, or and you can share different information and see if that resonates with them. Or if it doesn't, maybe they do have different values, and it's important to kind of accept that and not impose our own values on people, but to help them make the best choice. I did want to kind of build back on the previous question, though, in terms of students, because I don't talk about it as much, but part of my clinical role is training physicians and physician assistants. And I think one of the comments, or the question about what resources do we, when resources have been removed or are no longer available, or how do we handle this kind of shifting environment? I think this is actually the time when public health education, population health education, educating our students, about the sciences of epidemiology is really critical, because they more than ever now need to be taught how to be able to critically evaluate the sources of information. So, is information and guidelines on vaccines or other preventive measures, is it based on systematic reviews of the evidence? What's the methodology? Who are the committee members? How are they chosen that are making the recommendations? What are their biases? Are they transparent? All of those, I'm kind of doing kind of the high level, but all of the things that you learn in your courses become all that much more important, because you can't just trust that the process is working. You have to really kind of critically evaluate it.
So Dr. Smith, we come from the same background in epidemiology and biostatistics, and so I could ask this question to myself, and I can maybe follow up with my perspective as well, but you've been especially attuned with audiences that are developing policy, whether it's in the military or other organizations, and you're trying to make complex data intelligible to those audiences. That's one of your challenges. And to make that complex information palatable to these very diverse audiences. Has that job gotten harder, easier, or just completely different in the last 5 years?
Completely different. There was a period where they kept statisticians in the basement, and then there was a period where data was king for maybe the tens and teens. But now it's back to, well, I read this, so you're wrong, you're out. and they're building their storyline and where they're going with whatever policy based on what they're reading and what people are telling them that read probably the same areas. So the science has become kind of in the way in a lot, and quite frankly, with policy, there's a lot of different ways to bake that cake, and so they'll pick and choose where they're getting their information from, and many of them are reputable information sources, but they're not the best or the known correct information. And so I think it's gotten a lot harder for those groups because they're kind of moving quicker than the science is and quicker to the endpoint, which is often based on a lot of what they get off internet and other areas. So I think it's become really hard. And yeah, we can see that at the high levels, the highest levels, where people are maneuvering based on what they believe they're deciphering from information that isn't based necessarily in science.
This is a question for the entire group. Has public health earned some of the skepticism that it's receiving, even partially? And what are we doing wrong? Or what have we done wrong recently?
I think this goes back to communication, and you hit it earlier, Leah. I think we fail at communicating really well. And so, again, we're doing things by the book, scientifically based, and we're not as fast as what social media can do. So.
Yeah, I would add to that science is slow and TikTok is fast. And so nobody wants to go with the slow route, which is to build the evidence and to elaborate on it or even erase it in some cases where we find something to be false in the case of the early studies on vaccine and autism. And it's a slow process, and we don't embrace that. So how do we embed science back in, given those pace differences? And can we speed that, but also be clearer in our communication? And a lot of the discussion at public health national meetings these days is we have not been good at messaging, and we have not been good at being definitive and decisive in the face of the fact that some of our evidence, is always subject to change. And we just need to be as confident and forthright as those who don't have good information. Sometimes when we're talking about public health information, and we all saw examples of where that really backfired in the COVID pandemic, where there may have been partial or changing guidelines, and that really led to some of the skepticism. Any other comments on maybe the history of public health and how that has played into the current infodemic, which the World Health Organization has declared as a public health emergency, where we just have all this misinformation and disinformation spreading everywhere?
Well, I do think there are some opportunities where some organizations maybe have moved too slowly. Like one that comes to mind is the U.S. Preventive Services Task Force. And they really, are the gold standard for evidence. They do very, very rigorous systematic reviews that take them years to do because they're so rigorous. And I think, from kind of a pure standpoint, they do everything absolutely right. But at the end of the day, it may be like the perfect may be the enemy of good enough, because you do want your guidelines to, and the decisions they make impact whether or not whether or not Americans have a copay for specific services. So, it matters to people if they have a copay or don't have a copay in terms of whether they go get things. And so by trying to be so perfectly accurate, there are delays that I think, frustrate patients, frustrate clinicians. And so I think that's an example of, where there may be a little bit of flexibility might be helpful, and it's maybe not just even just messaging, but maybe like we need to take feedback and accommodate to what kind of the real world needs are.
I'll just add two quick thoughts. And one is, is a bridge to medicine, but I think I'd offer it in the realm of population health, which first answers yes, Sarah. That would be my answer. The first example would be early 1900s, the Flexner Report, which many of us know and exists in the great name of accreditation and standards. And in practice, it meant the elimination of medical schools that were serving students who were Black or African American identified. If you haven't heard of the Flexner Report, you can Google it. You can Google it so much to see if the Flexner Report never existed. Hundreds of thousands of physicians might likely exist. And why does that support my yes, which is back to Tyler's nod earlier, which is I do think we've gotten the message wrong and the messenger wrong. I do think the use of the E word, elitism, a critique of our field, a critique of many of us in higher ed, exists. And I think for many cases, for good reason, the Flexner Report is the first. It created a system for the haves and the have-nots, that high quality and standards, dare I say it, looked, right, or served a certain type of student body. The second piece I would offer is really in the same vein, but it's really also access to health information, and also access to people who, frankly, are maybe the best people to offer that information. With this example, I channel and offer the promotores de salud, and we think of our community health workers who are not just Latino or Latino serving. In my hometown of Chicago, they're Polish or Polish American. And they really are of and by the community, and for a variety of reasons, paying a community health worker, hiring a community health worker, licensing a community health worker, and I suppose that's not an air quote, those are very real issues, can also present hurdles. And I think those hurdles, be it my first or my second example, really highlight my yes, which is, I think, to be honest and say we haven't always gotten the message, but more importantly, the messenger right. And as an educator, I see that, and I should clarify, as a lifelong educator, someone who genuinely is interested in education across the lifespan, meaning inside and outside of these walls, or inside or outside of our Zooms, I see that as a call to action and a real invitation to do more.
So this last question, I know exactly how long the answers will last because it's built into the question. If you had 30 seconds with every public health student in the country right now, which you have some online, to tell them not about what's wrong, but what they can actually do right now, what would you say? What can public health do? And let me back up a little bit and mention the fact that Dr. Tom Frieden, who was the CDC director, has come out recently to say, I do not trust the current CDC director. Okay, and I do not, I don't trust the information that's coming out of the CDC. So it can be a discouraging environment to be a student. It can be a discouraging environment to be a public health practitioner. So with that current milieu of and unprecedented in my 30 years of public health, what do you say to that student about what they can do right now? 30 seconds. Each.
It's simple. What they find on the internet is the start and not the end, not what you submit. And that's the problem. I think most people are grabbing that first place and they're submitting it or using it. And that should be the starting point.
I mean, I would just say from my own experience in my career focused on population health, which is just sort of another way of saying public health, is that there's lots of different environments and places that you can kind of practice the craft and have positive impact. And so It may be that in certain public, um, federal circles that there are fewer options and you're not necessarily seeing the leadership, but there are lots of other academic, non-academic, public, private organizations that are still focused on the mission, and the work is there. And I may have gone over my 30 seconds.
That's fine. That's great.
I had 3 Ps. I was thinking principles, people, and power. Principles to really highlight public health science is a real thing. Revisiting it, knowing it. And then the people, this is both the people in the public health sciences and our kin and sister related disciplines, but it's our everyday people, it's our families, it's our communities, which links me to power. This is as much follow the money as it is many of us are from communities where we were raised to not trust the government for very important valid, well-documented reasons. And I exist in a spirit of thinking about power for ways that we can band together to do more in a solidarity that really is health and well-being serving, in tandem with we all get more together.
I suppose I should add my 2 cents being an academic program director for 2 Bachelors of Science and the Masters of Public Health program. I think similar to whatever panelists have mentioned is there is a lot of good work being done out there. And to maybe put your phone down, put your TV down, even though that stuff is overwhelming and important because it is influencing policy and it is influencing health. For the students who are impassioned and wanting to change the world, is to get out in that world, to see the work that public health workers are still doing, the great work that they're doing beyond those areas that are necessarily touched on by the onslaught of misinformation and disinformation. There are some areas in public health that haven't been touched, believe it or not, or aren't as susceptible to some of the scrutiny that that they've undergone recently. But it's not a comfortable environment right now in many cases. Navigating this environment of misinformation and disinformation. I would like to open the floor to questions from our audience, and you can direct them to any of us or all of us.
We're going to start with, we have some online people. So Tiffany, if you want to unmute, we'll see if we get too much feedback, we'll type it. But Tiffany, if you want to go ahead and ask a question or a comment.
Hi, good evening. Can everyone hear me okay?
No. 1 second.
Yes? Okay.
I can hear you, but we can't hear you in the room yet. Try again, Tiffany.
Hi, good evening. Can you hear me okay? Oh, perfect.
Yes.
Hi, my name is Tiffany Kmart.
Hi.
I am founder and executive director of Elevated Health and Community. So we partner with patient-serving organizations to provide strategy and consulting around community health initiatives, equitable care delivery, and also serve as appointment patient advocates. So first, I want to thank you guys for this conversation, but I really feel that a lot of what we're talking about around misinformation, disinformation, and access to information really has a lot to do with what we do and don't do as a system around our health literacy. I think there is an assumption that people know where to find good authoritative information and that they have the knowledge base to differentiate. And often, and I believe one of the panelists early on said, kind of understanding where and how people get their information, I think is really going to be the key, along with that combination of communication, the message, the messenger, and the provider relationship. Can any of you speak to any approaches that are proactive as opposed to reactive in combating health literacy or provider patient communication?
Thank you for the question. I think there's a checklist that you can go through anytime you encounter new information. And I think Dr. Smith highlighted this earlier, that the pace of things is often too fast and we're moving too quickly. And one of the first questions is the content reliable? And this is going to be a checklist, which I'd love to put up for you, but I didn't prepare a slide. But is the content reliable? That's just a fundamental question. And then who is the author? Who is the author? And that's something that we would often think about as public health professionals in terms of the quality of the paper, where did it come from? But now we're talking about what was the origin. Was this a website for a healthcare system? Was this a product? Was this a TikTok? And really think carefully about what that source of information is. And what is the source for their claims? So are they citing information? And then finally, how do you feel about this piece of information? Have you taken the time to reflect on that bit of information? Have you evaluated it critically yourself before then passing it along to someone else? Because that's really what's happening a lot, is a lot of people repeat what they hear and they didn't go through those steps of looking to see, is it reliable, who is the author, where did it come from, and does my gut trust this information? Does it sound right? And if it's, especially if it's something completely new, what is the basis of evidence? Those are some things that you can do every time you hear a news story. And as epidemiologists, biostatisticians, we're annoying. We hear the first 2 minutes of a radio podcast or something about new health information, and we go straight to the study design. We're like, what was the study design? Was it randomized? Was it observational? And we're trained to do that. And you're right, though, that most people don't have that kind of training. So it's really a more basic question of, really thinking deeply about those sources of information. But that's not enough always, but it's that enough caution that it slows that pace of the transmission of misinformation and disinformation, that you've taken that time to think about it, and that certainly helps stop the spread. It's not a perfect immunization, it's a partial immunization. Other panelists?
I had two quick, and they're anecdotes. To Sarah's last pieces, I was at a national meeting, a national academic public health meeting 2 weeks ago, and there was a big name national communication expert that says in matters of social media we have 3 seconds, and this would be like Instagram, TikTok. 3 seconds when something appears, so 1, 2, 3, and you decide to stay with it or pass, swipe, or whatever. So that's like one thought just to have in terms of audience, which was the second piece I wanted to make. And it's really a comment on our aging populations, or gerontology. I have the virtue of having 2 grandmas still with me down here in the earthly realm, 86 and soon to be 89. And it is fascinating to me to talk about this information with them. And I should clarify, to listen. And to find out on a recent trip home for Easter, right, the hometown print newspaper is no more. Suddenly, the turn television and the bunny ears that could give 2, 5, 7, 9, and 11. That's a Chicago TV. I have a Chicago audience member here nodding along. Right, that's been long gone for some while, but the access to information is very much not what it was. And so we're talking about information to a huge swath of our population. And I think for me, to the question, really is on literacy, and also for me, design.
So, I'm sure you've heard that correlation does not imply causation. I'm sure you've heard that correlation does not imply causation. And we've seen this recently at a high level in the U.S., talking about aspirin or Tylenol. At any rate, I always go to it with a viewpoint. I try to teach my kids to look at it Like, just because it's correlated doesn't mean it's a reality or cause. But Hill, actually, if you're an epidemiologist, you know Hill's criteria. And so you want to roll through it, and I wrote them down with a different context, so I won't go into it. But the strength of what you're reading, the consistency, are other people saying it? Are there research projects saying the same thing? Specificity, is it specific to that, whatever you're reading? And this is Hill's criteria if you want to look it up. Temporality. So in our world, does the exposure happen and the outcome happens, right? So is it a cross-section that you're looking at, and that's where you're coming up with your information, or is there true like a pathway that you can follow? The biologic gradient, which is if there's like a dose response, right? So the more of that would create more of an issue. Plausibility, does it make sense? A lot of times people look at it and go, wow, that's cool, and they send it on without even thinking about does that actually make sense in real life? Experiment. Do you see any experiments happening? Usually you can't do it on people, but do you see large, like ecological type of experiments happening where that would dispel that? And then analogy. Are there other forms of it happening in not necessarily the context you're looking at, but in other contexts? So there are ways to go through before you hit that forward button to kind of get a gut check on whether something's real or not.
We have
Other questions?
one more quick question from Kay online. She's asking about what effect is artificial intelligence? Are they changing the sources? What are the sources? And is AI affecting that? What should the source be for public health?
So those are algorithm based, and you can feed it whatever you want to build it. And some algorithms predict certain areas really well. In the 90s, we were using medical journals to predict open-end text questions that the military were providing us. So you can prime it with whatever you want, and those will feed into those algorithms. Now, typically, the mainstream algorithms we're all using, we feed those. But there are specific ones that are in specific areas that would be fed by a different chalkboard. different.
Yeah. I mean, I'll just add on with, I think the outputs of the AI models are only as good as the inputs. And so, I think most of us, if we see the AI summaries at the top of Google, and you go look at those sources, they tend to be very, very general, generic, not high quality sources. They're kind of like articles that are summarizing a review article, summarizing another review article, and you'd have to go probably 5 layers back to get any kind of source material. On the other hand, if you were to design a very specific search using Hill's criteria, and saying you want only the studies that include, that you could specify randomized controlled trials, or you could specify different criteria, and you spent several hours, you could probably design a prompt that might bring back pretty good quality data. But you have to do more than just say, ask the generic question.
Yeah, it's unfortunate that right now the best information is behind a paywall, right? So a lot of the best journal articles, New England Journal of Medicine, you have to pay to get access to that, and AI does not have access to that information. I know even in the non-medical world, you want an Atlantic article or a New York Times article. I'm not saying those are the best publications, but they do, some pretty good investigative journalism, and you have to pay to get that information. And what AI gets is what it can get access to, and that's usually the cheapest, easiest, and most abundant. And we all know that that is not the standard by which journalism or medical information is judged, right? How the quantity of it. And so, though it can do some discernment as AI, it can sort through things. It is fed so much garbage, for lack of a better term, relative to gold standard evidence-based information, that it is inherently biased towards, as you mentioned, abstracts of articles as opposed to the whole article. And if you read a whole article, that's where you get the nuance, right? You can't put enough in there, just caution about, interpretations. limitations of the study. These are not normally highlighted in the abstracts, and that's all AI has at its fingertips. And so this is a big problem, that AI is being fed the worst of the massive information that's coming out. But it's not something that's entirely new. There was a tendency for the media, mainstream media, to cherry pick articles or interesting, newsworthy medical information, often at less than rigorous, maybe peer-reviewed, but not quite as rigorously reviewed. So they would go to conferences, or they would go to, small papers and really emphasize that information and bring it to the surface, as opposed to really doing the research to see what's really going on, or what the scientific community is saying about something. And so AI is no better at that. It's being fed not only the most common information, but also a lot of that amplification that happens from the media as its source. So I went on too long with that answer. But questions from the physical audience here, or person here, says Sheena. Oh, we're going to wait for the microphone to get to you.
I just would like to know your suggestions of what we can teach our children, and I guess for me, grandchildren, K through 12, that will improve their public health literacy.
That's a great question.
I'll start. It was 1990. Oh, wait, are we doing multiple questions before we answer? No, I can answer. I was trying to stage and age myself here. It was 1995. This is a high school example, which is I took speech and I took critical thinking. Neither one were required in my small town, rural Illinois high school of 600. And I think a lot about those more recently, because in a faculty meeting we discussed how we need to be teaching persuasion. And I paused to think, when was the last time, aside from my undergrad training, that I learned and thought about persuasion and critical thinking? And it was those high school classes. Unbeknownst to me, I thought they sounded interesting, and I knew they had a great teacher. So I thought I'd just start with two nods to the past.
Well, I certainly wouldn't rely on the education system itself to teach those skills. As we know, the health curriculum has become almost non-existent, especially with respect to sexual education, but really health education in general. I think one of the biggest challenges we have in public health is thinking about populations as opposed to individuals. Now, that's way too broad of a concept for kids to understand. However, you could start to teach things about, for lack of a better term, the externalities of what their decisions are. So, for example, when they, is it really a big deal if I were to drop a piece of litter? Is it really that big of a deal if I drop my candy wrapper into the stream? Well, you start to ask questions about, well, what if 1,000 people did that, or 1,000,000 people, and the aggregate effects of your behaviors. And we so often do not think in terms of aggregates. We often think in terms of individuals and individual behaviors. And that's really, I think, the big problem with the COVID pandemic, is everybody kind of thought about, how does this impact me? And do I need the vaccine, without any understanding of how vaccines work? It's really not about you. It's about the herd. It's about protecting others. And so coming up with those little examples of how their choices impact others, whether it's their community or larger levels of people, collectives, that kind of thinking, I think, really needs to start earlier, to think about how your choices not only affect you, but affect others. And often with public health initiatives, it isn't until our behavior affects others that we start to implement change. So smoking really did not get the policy muscle that it needed until secondhand smoking became an issue. And that's when we started to see restaurants banning smoking and things like that. So it's giving that kind of insight about kind of collective versus individual that I think can start very early, and it doesn't have to be about health.
So I have another high school, it's more of a high school one, which is that a lot of students in high school are encouraged to take calculus or pre-calculus, which, you know, for most of them, they probably won't necessarily go on to use in their lives, but more and more high schools will offer statistics. And I think statistics can be, it's certainly very valuable for public health. Most life sciences, I think it's a good background, and a lot of, you know, other areas like finance and things. So I don't know, I think I tend to try to encourage students to take, unless they, you know they want to do engineering or physics or something that really requires calculus, that a statistics class may be actually a much more useful in the long term.
Other questions from the audience? Yes.
How you doing? Brian McLean, annual alumni and fine art photographer. So my first question is, how do you build trust in communities that historically didn't trust public health? And how do you discern between perspective and truth?
Ooh. I'll take half of it. One thing that public health did not recognize early enough is the importance of embeddedness within communities and having voices within the communities, as opposed to being us as a public health entity talking to communities. So really getting community participation in projects. And there have been movements within public health recently, community-based participation in research from the very beginning, even setting the priorities of what are the health issues facing our community, what do we care about in this community, rather than saying, here's what we think, this is what we studied elsewhere, and we think we need to do it here, and we need to do it everywhere. And I think it's not even about specific groups. It's really hard sometimes to translate effective interventions from one community to another. Even across cities, they're very different. And recognizing that, we've been way too slow at that. And so though we have made progress, there's still a long way to go as far as making sure that it is truly a collective enterprise, the work of public health, and getting everyone involved. And that also goes back to the childhood education thing, that people are equipped to take that role.
I love that question. Thank you so much. I was thinking of the latter piece, the second question related to the first. It was right, perspective and truth. It is, and I think something that is the truth, objective truth, and how that just might not exist as one within one's realized sense of life and life around them. And the thing that comes to mind, this relates to the first part of the question, is what I just think of is like, how, this is me, how can I serve in a way that there's a positive change? And I really should probably positive air quotes, because in my mind, positive is what is in the best interest of that person, their perspective, and the community. I think the area, though, obviously to bring out, and I think a lot of my work in harm reduction as the example, which is still promoting healthy behaviors, which might also just be reducing risk. And I think taking them both together, I will close by saying how much we all have to do in checking our egos about this work. And also challenging ourselves. And the really quick example I'll end with is spending many years in Chicago's South and West Sides in specialty clinics, which a specialty clinic is an STI clinic. And in settings that I was not from, so a literal outsider, really believing and wondering how I might serve. And in a variety of settings, it just happened that folks actually wanted to talk to an outsider. They were really happy to have conversations about their health. And then in other settings, I was absolutely not the person that folks wanted to be real with. And so I used ego intentionally, because if I am like right with my purpose and right with our science, together, right, I'll be showing up in ways that in my mind promote that health. But thank you again for the perspective and truth piece. I think if I think of that as an arc moment for many of our conversations, that's really powerful. Thank you.
Are there more questions from the audience or from online? Well, I do want to mention this is not the end of our Public Health Week activities. We have an upcoming book discussion group on Friday with Dr. Gina Piani, who, if you had the pleasure of seeing Dr. Piani cook a whole fish this morning, she's not just a cook, she's also a scholar and a great teacher, and she will be leading a discussion on the book Everything is Tuberculosis. You do have time to read it, although I do hear it is in high demand at the local public library, so you may have to actually physically buy a copy. I have a copy. I was supposed to show it show it to you all, but I really think this book has the opportunity to be a conversation piece for communities about health and public health, and it's really important. These books have been important, I think, to get new people into public health. For me, it was Mountains Beyond Mountains by Dr. Paul Farmer, which discussed the structural inequities that resulted in the many health issues and human rights issues happening in places like Haiti. And so he really created this global health movement from one book. And it actually wasn't his book. It was Tracy Kidder, who followed Dr. Paul Farmer's life. And so this book, I feel like, likewise, is just really transformative in how it has you view health and our role in it. So join Dr. Gina Piani in a discussion Friday at noon, correct?
Yes.
Thank you.
The audio
Same link
is
as we
6
have.
hours, that's all it is. So you can listen to it 6
Oh,
hours.
audiobook is 6 hours.
It's
So
at 1.0 or one times listening, right? One time.
if you want the Mickey Mouse version, it's 3 hours. Well, thank you. I would like to thank everyone who organized this event, including Dr. Mike Myers, who is the department chair of the School of Health Leadership and Services, or maybe I got that backwards, Services and Leadership here at the School of Health Professions. I'd like to thank our panelists once again for joining us today. And like any public health discussion, I hope that you are encouraged and not discouraged by having these kinds of conversations, because I think it's important that we address both our strengths and our weaknesses as we move forward. Thank you.